Thank you, Angad. Good morning, good afternoon, everyone. For those who do not know me, I'm Victor Zibara. I'm a PGY1 categorical internal medicine, and I'll be presenting the afternoon report today. So for today, our chief complaint is a 52-year-old gentleman presents to the ED at Mount Sinai Morningside for dyspnea. The patient presenting complaining of a 2-month history of exertional dyspnea, fatigue, palpitations, since returning from Mali, city of Bamako. The patient has been living in the States for 22 years, visited Mali for 5 months, and then returned to the States. Symptoms started upon returning to Harlem, New York. The patient reports worsening of exertional dyspnea, limiting activities to 300 meters or flight of stairs. The patient endorses substernal chest tightness, which lasts less than 10 minutes, exertional, non-radiating, and non-pleuritic. He denies any fever, he denies any dizziness, lightheadedness, diaphoresis, fever, chills, orthopnea, lower extremity edema, or coughs. He also endorses a weight loss of 10 pounds in the past 3 months, along with decreased appetite, denying any abdominal pain, nausea, vomiting, constipation, or diarrhea, hematochezia, melena, dysuria, headaches, and blurry vision. The patient denies any sick contacts or exposures. He did not take any preventive vaccines or malaria chemoprophylaxis in Mali, no recent history of insect bites, no hiking, no new medications or herbs. Previously, he had similar symptoms 8 years ago, which occurred independent of travel. He was admitted to Mount Sinai Morningside at that time and received 2 transfusions. Past medical history, as I previously mentioned, blood transfusions 8 years ago for anemia, which was not worked up at the time, and we weren't able to pull out any records. No past surgical history. Family history is positive for hypertension, but no significant oncological history. And as for his social history, he lives in Harlem for the past 22 years, only visited Mali for 5 months and came back to the US. He's not COVID vaccinated, does not go hiking, does not go to parks, including Central Park, no pets or known recent animal bites. He does not follow up with a primary care physician and has not underwent a colonoscopy before. He's not sexually active and reports occasional alcohol, no smoking, and no drug use. He's not taking any medications and has no allergies. And as for the review of system, in addition to what was mentioned in the HPI, he reports weight loss, change in appetite, shortness of breath, chest pain, and palpitations. Otherwise, his review of system is negative.
Let's just take a pause here and give everybody the opportunity to ask any more questions. Any questions you have about history, review of systems, or past medical history, any other collateral you would want?
Victor, can I ask you something? Just so he's been living for 22 years in New York. He went to Bali for 5 months, and then he came back. And when he came back, that's when he started to have the symptoms.
Correct.
And then
in the States, yes, in the States for 22 years, goes to Mali for 5 months, then comes back to the States, and upon returning to the States, his symptoms start.
Okay, got it. Thank you.
Then in the chat, I think Sonal is asking what's the patient's ethnicity?
The patient is African American.
And Sidra asks family history of blood disorders, coagulopathy.
No family history of blood disorders or coagulopathy. The only thing that we know is that he presented to Mount Sinai Morningside 8 years ago and got 2 units of packed RBCs.
Sounds good. Any other questions anybody wants to ask before we move on?
Is the weight loss, I guess, not intentional, right?
Yes, it wasn't intentional.
All right, let's go ahead.
Okay. So vitals and physical exam. Upon presentation in the emergency department, basically, his vitals were stable. He was his heart rate was in the 94, 98, systolic blood pressure in the 120s, 140s, and saturating at 100%. He was pale first encounter. HEANT exam was normal. No lymphadenopathy was. Cardiovascular was positive only for a murmur in the mitral area, which was a systolic murmur. Pulmonary exam was normal, no additional sounds, good bilateral air entry. Abdominal exam, We did not appreciate any hepatosplenomegaly. A DRE was done, which did show light brown stool. MSK exam, no edema. Neurological exam was intact, and his skin was warm and dry, with some darkish spots on the palms.
Before we go back, let's go back to the physical exam. Any questions about physical exam? Anything you would assess in addition to the things which have been described?
Did he have any splenomegaly?
No splenomegaly.
Why did you decide to do a DRE?
The main reason they chose to do a DRE because the patient reported that his stool was initially dark, but he wasn't sure if it was black dark or brown dark. So they decided to do a DRE either ways.
Okay, thank you.
Denise, the question should be why not a DRE? You should always, when in doubt, always do the DRE.
Okay.
Something which I will tell you next year as well. Any other questions or anything else you want to assess? So this is a patient who has, potentially has some blood disorder. He's pale, low murmur. And what do you make of these darker spots on the palms?
Let me give you some more information about those dark spots on the palms.
Do we have a picture?
Unfortunately, we don't have a picture, and it's very it wasn't like immaculate or popular rash. It was very non-specific. The only thing that we were able to see was that the palms were some spots were darker than other spots, but it was very non-specific. And unfortunately, I don't have any pictures for that. But it's not something that raises like any red flags raised any red flags for us.
People are asking if it was if these lesions were painful. Could they be purpura?
It's not purpura, it's not petechiae, it wasn't painful, it was painless. Not Janeway lesions. Patricia said syphilis, what do you mean? Oh, you're just, okay. Any collateral history being confused? No, no confusion. The patient lives with his brother and there's no history of confusion.
All right, Dayo, could you tell us what you're thinking about with this confusion and non-urine output? TTP, all right. That's a good thought. Are the spots blanchable? That's what Rafa's asking.
No, they're not. It's just dark spots on the palms, not blanchable.
Right. Thinking about changes in the hand of people with anemia, this patient potentially had anemia in the past. What are changes you could see in different etiologies for anemia? B12 deficiency, you could have, neuropathy. If it is autoimmune, you could have, pigmentation, things like that. Anything else in more common causes, etiologies of anemia? Iron deficiency, can you see something in the hands or the nails? Yeah, good. Koilonychia. If you just combine your attempts, you spell it right. It's koilonychia. All right. Anything else on exam you can see for a patient you're suspecting with this? So what are the things you're suspecting? This is a patient with shortness of breath, some exertional chest pain, and this previous history of anemia. So what are the things you want to rule out? What are the things which could, which you could see in a patient like this in your physical exam, which could help guide your workup? So let's not think about specific diagnoses like endocarditis, but it could be cardiovascular, it could be respiratory, and it could be hematological, and then it could be miscellaneous. So you want to make sure your cardiovascular exam is good, right? You want to make sure if there's a murmur, you're listening for it. Before labeling it as flow murmur, you have to know the causes of murmurs. When do you see flow murmurs? Then you want to make sure your respiratory examination is good. The patient's not hypoxic. There's no pulmonary, adventitious sounds in the lungs. The breath sounds are good. The patient doesn't look cyanotic. Then hematological. All right, hematological, as Omar said, great point. Always palpate the spleen. Do a thorough skin examination. Look for signs of, for purpura, any ecchymosis, and signs of coagulopathy. And then you can always have these, weird rashes or other things which you can see in a lot of multi-system disorders. All right, let's move forward.
So what labs or imaging would you order at this point for this patient?
Just let's go to the next slide. What we'll do is everybody can annotate. So when you press up on the view options, you will see annotate, and then put a check mark against which tests you would want right now. So each test has a certain dollar value, right? Whenever our patients come in, it's not as if they're charged a package and then everything is included. It's not. Every test you order, they get charged for it, and you might be paying for it, we might be paying for it, the patient might be paying for it, but at the end of the day, it costs money. So let's be cognizant of that fact and choose which test you actually need based on what your assessment is as of now. So yeah, everybody go on annotate the top, and yeah, like Dio did, just put a check mark against whatever test you think you need, or put a star.
Yeah, so just so you guys know how to do this, when you go to the top bar of your screen and it says you're viewing Victor Zibara's screen, there's view options right next to that. You click on view options. The third option should be annotate. When you click on annotate, you get like these options to draw, use a stamp, to maybe put text. So you could do whatever you like.
So lots of buyers for CBC, no buyers for coax yet, CMP, a few, some for Troponin BNP. Some for everything. Nobody wants a lipase? Okay, that was, I wasn't asking you to, I mean, just if you actually want it. Okay, anybody wants to explain why? So who is this tick mark? Who selected VBG? Anybody?
I did. It was me, because like if he's like complaining of like dyspnea, I mean, I want like to make sure like his SATs, his like oxygen, or like, that's, but apparently I'm the only one, so forget about it.
No, that's a good point. So if you want to look at his SAT and his oxygen, would a VBG give you any information about his oxygenation?
No, like we could see more like pH and like CO2, but obviously if it's venous, you would not get like
Exactly.
O2.
If you're looking for oxygenation or the patient's gas exchange, you're looking for an arterial blood gas. A common surrogate, what you see in an arterial blood gas is something called as a partial pressure, which is a surrogate for patients, or you can use oxygen saturation, which is on your vitals, which is a surrogate for the patient's gas exchange. And if the patient's healthy appearing and the patient has a normal side, you can use that as a surrogate that, okay, this patient's has decent gas exchange, and then you don't need to torture the patient with an arterial blood gas. A VBG will give you a pH, that is correct. It will give you a PCO2, it will give you some other things, but in this case, I'm not sure if pH or a PCO2 will help, because if the patient came in with COPD, the patient seemed like the patient was altered, that would help you with PCO2, or that would help you to rule out hypercarbia. But in this case, I'm not that convinced that we need a VBG. Troponin BNP, anybody want to chime in on why or why not, if anybody feels against it? Anybody feel that this is an ACS and needs to rule out a troponin? Needs a troponin to rule ACS out?
He's having chest pain and dyspnea, so troponin to see if there's any damage to the heart, BNP to see if there's any signs of heart expanding, fluid overload, congestive heart failure. If he's also very anemic, like it could explain the chest pain and the dyspnea, but you don't know until you get the results. So,
okay. All right. So let's talk about troponin a little bit. So troponin, if this patient has 2-3 months of chest pain, right? It's exertional, it happens. Do you think this patient is having an ACS right now? Exactly. So troponin will help you rule out an acute coronary syndrome. It won't help you rule out even if it's like 0.4, 0.5 in this case, what you start your workup with is an EKG. If you think this patient has acute chest pain and you need to rule out ACS, or it has an anginal equivalent like acute shortness of breath, that would help. That if that's you want to rule out an ACS right now, that's where a troponin would help. A BNP is a separate scenario because it would help you rule out CHF in a patient with subacute dyspnea, subacute to chronic dyspnea. All right? Do you get why I say that troponin might not help in this case? Right. Let's move forward and show.
And just a second, so just Dio, you made one really good point, right? Like you're wondering if they're not anemic, then should you be looking for heart failure? So just remembering that instead of having this kind of kitchen sink approach where you just throw 6 labs or 8 labs at someone, perhaps looking for what you think is the most likely diagnosis, checking for that before moving on to the next test. There is value to that, right? So that if the same patient was not in the emergency room, if the same patient was at the Ryan Chelsea clinic, would you really order this full panel?
Okay, let's see what workup was actually done. Victor, yeah.
Yep, this one.
Victor, the thing is, you will have to erase this before you move on. So let's clear it. Yes, and then you move on. Otherwise, it'll just keep transferring to every next page. Okay.
Okay. So we got some of the labs we got, other labs were gotten by somebody else. But most of the labs that we previously have on the previous slide were ordered. So a CBC with a differential, which cost $13, showed a WBC count of 4.9 with a normal differential, a hemoglobin of 4.6. The RBC count was at 1.71. RDW elevated at 29. MCHC was normal at 33. And an MCV, which was at 79.5. The retic percent was 0.9. And the platelet count was at 141. Otherwise, PT, PTT were normal. CMP was showed an elevated AST at 159 with a normal ALT. Total BD was elevated at 1.3 with a normal direct BD. Lipase was normal. VBG with lactate was normal. Troponin was normal, and a BMP was normal as well.
Before we move on, if I can just request you guys quickly to look at those prices and do the math just quickly mentally yourselves. You know where you put the check marks. So figure out how much money you've spent so far. And we can keep going, Victor.
Okay. So based on the labs that we just got, what additional labs would you get next?
Anybody want to volunteer?
I'm just going to go back to the labs so you can have an idea. So these are the labs. Based on those labs, how would you proceed?
So Kruti's chat, put something in the chat. So iron panel, LDH, apto, retic, peripheral blood smear. Patricia says blood smear. Umar says blood film. So good. Kruti, do you want to unmute and tell us your rationale for all of these?
Yeah, so I guess like this would be acute, acute onset. I don't know what his prior baseline is of hemoglobin, but I know it's 4.6 now. The MCV 79.5, I'm thinking microcytic. If I think and he's African American, so thalassemia or iron deficiency would be on my differential, but his RDW is high, so I would probably go for acute iron deficiency, iron deficiency more because the red RDW is high. Retic is low. I know if it's if I'm thinking hemolytic, it probably should be high, but if he has at the same time another baseline anemia, which is preventing him from having or a bone marrow, I don't know, which is preventing him from having reticulocytosis. So I would want to rule out hemolytic anemia also, and peripheral blood smear just because of his entire history.
Good, great points. Sonal says we should get electrophoresis before we transfuse. Why do you think we need an electrophoresis?
Given his ethnicity, he is African American. He has a history of anemia requiring blood transfusion. So I would want to rule out hemoglobinopathy, but it's not the most cost-conscious decision, I know.
No, that's a good thought. So let's talk. What's your differential? Which hemoglobinopathies are you suspecting?
Thalassemia, because it's microcytic. So thalassemia is common in African American population. Sickles are less likely because he's an older patient with no episodes of like sickle cell crisis. So I'm not very worried about that, but at least thalassemia.
Right. So just as Dr. Singh said, like, we're trying to think about cause consciousness. So the approach would be, what's the more common cause of microcytic anemia? Is it iron deficiency or thalassemia, which would be seen for the, in a patient with this age?
Iron deficiency would be the common.
So thinking, not just saying that we'll do all the labs, but thinking first, what's the most common or most likely thing? And once that is ruled in or ruled out, then moving on to the next step instead of ordering all of them together is what we're trying to, but that's a good thought, that if you're thinking about transfusion, then you might want to take that step earlier. Some other points. So Sherelle says LDH. Yeah, we talked about that. And then parasite. Newman, what parasites? Anybody else want to? We talked about strongyloides. That I'm not aware of strongyloides causing anemia. It usually causes a diarrhea with elevated IgE. But thinking about this patient who has a recent travel history, it could have a tick-borne infection, or it could have hemolytic anemia because of malaria. Yeah, good point. So malaria is, especially in a patient who hasn't taken prophylaxis. All right, let's move forward.
So the additional labs that we got were iron studies, which showed an iron which was slightly elevated, a ferritin at 644. The transferrin saturation wasn't able to be calculated in the lab, and LDH, which was high at 600/407, a negative Coombs, and a haptoglobin which is less than 8.
Anybody want to help us interpret these iron studies, and tell us about their approach to interpreting iron studies? What's the first thing you look at in an iron panel?
Ferritin. If the ferritin is low, I think of iron deficiency. If it's high, it's very non-specific. It could be inflammation.
Great. So you also have to know what patient you're looking at, right? If it's a patient with an acute illness, potentially COVID or any other acute infection, ferritin is a non-specific inflammatory marker, so it's going to be high. But if in a patient in steady state with the low ferritin, that's virtually diagnostic of iron deficiency anemia. But in this patient who doesn't have any other concurrent acute illness, ferritin being normal goes against iron deficiency anemia. When the ferritin can't be, when there's confounders with ferritin, what other things can help you diagnose iron deficiency anemia? Anything else? Umar says TIBC. What happens with TIBC? So TIBC is total iron banding capacity, right? So that's elevated in a patient with iron deficiency anemia. The other things you can look for are transferrin saturation. Transferrin saturation below 15 or below 12% is also increases the likelihood of iron deficiency anemia. And a newer, more expensive modality, which is used very widely in cancer hospitals, but it's not cost conscious at all unless every other test is non-diagnostic, is soluble transferrin receptor. So that's the least cost conscious, but it's the most commonly used. You just have to know that's used when there's confounders for every other. So transferrin saturation cannot be calculated. Ferritin is high because of other confounders. That's when you'll be using a soluble transferrin receptor, and that shouldn't be the first step. And then the majority of your patients will have low ferritin, low iron, high TIBC, low transferrin saturation. Okay. Anybody want to talk about? So we said that the ferritin is high or ferritin is not low. we don't think iron deficiency is likely. Anybody wants to interpret the other three tests on the slide? LDH is elevated, could be hemolysis. And what else suggests hemolysis here?
Haptoglobin, it's low as well.
Great.
So it's binding.
And then when you're thinking of hemolysis, what's your differential? What are the types of hemolysis?
Intravascular, extravascular, intrinsic, extrinsic.
Okay, give me examples of intravascular and extravascular. When do you see intravascular hemolysis? We talked about a few already, and you have one on the slide which rules out one cause of intravascular hemolysis. So John says MAHA, that's true. That's one. TTP we talked about. Any other cause of intravascular hemolysis? The Coombs is there, right? So autoimmune hemolytic anemia. What are causes of extravascular hemolysis? When it's not happening in the blood vessels, where is the hemolysis happening then? It's happening in the reticuloendothelial system, right? It's happening in the spleen, lymph nodes, liver. So extravascular hemolysis is when there's hereditary spherocytosis or anything which is increasing the phagocytosis of these blood cells in the reticuloendothelial system. So membrane defects and any hemoglobinopathy can cause extravascular hemolysis. And that usually manifests as hepatosplenomegaly, lymphadenopathy, and hepatomegaly as well. All right. So we see that the direct Coombs is negative. So although this patient is hemolyzing, this patient probably doesn't have hemolytic anemia. Okay, next, Victor. Let's go on.
Sure. Okay, so at this point, just before I move on, our main differentials and the things that we were thinking about were obviously a hematological problem, but two additional things we were concerned about were one, a possible malignancy versus making sure that the heart was fine. So the next steps that were done were actually getting an EKG, which was unremarkable, a chest X-ray, which was also unremarkable, a CT scan, which did not show any evidence of hepatosplenomegaly, a very small pericardial effusion, and no evidence of metastatic disease in anywhere. We got a chest, abdomen, pelvis, and a chest, abdomen, pelvis CT scan. A TTE was done showing mild pulmonary hypertension, normal valves, ejection fraction of 60%, and no diastolic dysfunction. And I was very surprised that this is super expensive.
Exactly. Let's just take a pause and take note of the cost of an echo, how easy it is for us to order an echo for every single patient, but that is incredibly expensive, especially if this is inpatient, right?
Victor, can you remind us what the BNP was?
It was normal.
Okay. And you had a systolic murmur.
Yes, this is systolic murmur.
Do you know the systolic murmur resolved after a blood transfusion?
I'm not sure.
Right.
So this is going to help us with a problem representation.
Anybody want to take a stab at it? We can go back to the first few slides to tell you about.
Sure.
Who wants to try? Denise, you want to help us?
Okay, so this is I think the patient has 50-something years old.
So yeah, let's bucket that
Yes.
into category.
It's a 52-year-old gentleman.
Middle-aged, let's say middle-aged.
Sorry?
Let's bucket that into a category because, you know.
Oh, this is a middle-aged male that comes in complaining of exertional dyspnea, fatigue, and palpitations. Presenting with systolic murmur. What else? He had in the physical.
Let's think about problem representation in steps. So first thing in the problem representation is who is the patient. So you said he's a middle-aged male. Anything else? Any other descriptors which are important in this patient? So this patient is from Africa with recent travel to Africa.
Okay.
So all of those are important things in, having a framework in mind. You want to have a picture of who the patient is. So middle-aged male with African American with recent travel to Africa, who comes in with now we talk about what clinical syndrome he came in with, right? So that's now you talk about he came in with exertional dyspnea, shortness of breath, palpitations, and chest pain.
Big impulse palpitations. Who presents with,
anything pertinent on his physical vitals?
and yes, I was going to that. Presenting with a systolic murmur in the mitral area. Also, he was presenting with.
And now we talked about his pertinent physical examination. Now let's talk about his pertinent labs. Seem to have.
Yeah, and dark spots. With labs significant for low hemoglobin, low platelets, possible hemolytic anemia, maybe.
That's a good way of putting it. So anemia and thrombocytopenia. So
thrombocytopenia, yes.
Yeah, this would be a bicytopenia, right? Thinking of it in more like scientific terms. So presenting with a bicytopenia and elevated hemolysis markers.
Yeah.
All right. So middle-aged male with history of travel from Africa, African American, presents with subacute to chronic dyspnea on exertion, chest pain, palpitations, seen to have severe anemia, this hemoglobin is 4.6, and thrombocytopenia with elevated hemolysis markers. So that puts everything into 1 or 2 lines and evokes a picture of the kind of patient you would have. Let's go ahead. Victor, can you show us what you came up with?
Sure. So middle-aged African-American man with no past medical history presenting for chronic progressive dyspnea, intermittent palpitations, fatigue, and weight loss, found to be anemic and thrombocytopenic with elevated hemolysis markers.
Great.
Sorry. Okay. So I'm just going to talk for 2 slides on how we approach anemia and particularly how we approach isolated anemia. And basically there are two ways for anybody to approach anemia. You can either approach it with basing it on the reticulocyte count or basing it on the MCV. And we usually have a tendency to base it on the MCV more often. However, 3 important things to keep in mind are the clinical history of the patient, the labs that we have, and a peripheral smear of that patient. Once we have that data, the reticulocyte count will be able to determine and categorize our diseases into 2 main buckets. If it's increased, then we think about blood loss or hemolysis, versus when it's normal to decrease, and this is where the MCV comes into play. Thinking about microcytic anemia in the cases of iron deficiency anemia, thalassemia, or late anemia of chronic disease, and normocytic anemia, which is early anemia of chronic disease, renal problems, thyroid problems, and bone marrow problems, and eventually a macrocytic anemia with vitamin B12 deficiency, folate deficiency, which is less common, medications, and aplasia of the bone marrow as well. So this is one approach. This is just another representation of the same thing, where we're basing it mainly on the reticulocyte count that we're getting, and based on the acuity of the events, and enough. And again, talking about hemolysis and bleeding in the patient in the cases where the retic count is high, versus in the cases where the retic count is low, we're thinking about bone marrow dysfunction, which is either intrinsic or extrinsic, versus not having enough building blocks. And this is where the MCV takes place, again, with macrocytic, microcytic, and normocytic anemias. So during our hospital stay, the patient was initially transfused 3 units of packed RBCs. The hemoglobin increased and stabilized around 8. Unfortunately, peripheral smears were not collected before the transfusions were done, and the ones that we got after the transfusions were done were unrevealing. And initially, the patient was started on doxycycline due to concern for tick-borne diseases and atovaquone proguanil for malaria. given the history that the patient has recently returned from Mali, and given the fact that he wasn't on any chemoprophylaxis over there.
All right, so I think we still don't have a diagnosis. We have this patient who's been in the hospital for a few days now. You stabilized, you've given them transfusions, but we don't have a diagnosis. But we've spent a lot of money already, right? We spent almost $2,000. So we now have a limited purse. We have very little money left, or the patient's going to, we start paying out of pocket. And now you still have to decide what further tests you want to do at this point to get your clincher diagnosis. So what we're going to do is we're going to go into breakout rooms, and each room is going to come up with the next steps, which they would order to get to the diagnosis or in the least possible, spending the least possible money, right? So we're going to open the breakout rooms now, and we will meet in about 5 minutes at about 2:41 or 2:42. All right, who is going to be our group leader? Umar?
Yeah.
All right, so you're going to be representing our group when we talk about what our workup is. So what do you think? What do you think should be the next step in diagnosis? What do you think is needed? So we have this patient with severe anemia. We've ruled out iron deficiency. The patient had microcytosis. We had elevated hemolysis panel, and we have ruled out autoimmune hemolytic anemia. What else could be possible?
I think like blood film is not expensive, and at the same time, it will help us to know if there was like any parasitic infection that is causing hemolysis. His bilirubin was elevated initially when he came, and the LDH was also elevated.
Okay. So we did get a peripheral smear. It was negative. We didn't see a parasite. So any other tests you can do to rule out parasitic infections?
What about if we do a blood smear?
Yeah, that's what we were just saying. Blood smear was already done. It was negative.
Okay.
But any other tests? What smears? What are you looking for in the smear?
Okay, it can show sometimes like intracellular, like if the patient was what they call it, if the RBCs had like some intracellular
Ring form, and you're talking about the parasite, like malarial forms.
Yeah.
So that's one. So the other thing you can do for malaria is you can do the antigen tests, right? So there's Plasmodium falciparum antigen-based tests, ELISAs. So that's one possibility. But we do have a peripheral smear which is negative, and the patient's being treated for malaria with atovaquone proguanil, but no response. So what else can cause hemolysis but not manifest?
It can be extracellular, extravascular. Like we know that on the physical there was no splenomegaly or no hepatomegaly, so we can. Ultrasound is not invasive and not expensive compared to the other imaging.
Okay. This patient also has a low retic count. What does that signify?
Like a bone marrow, like bone marrow issue. So
anybody else wants to? Jonas, want you tell us what can cause a low retic count?
Yes, any form of bone marrow suppression, I guess, could be viral, could be some sort of malignant disorder, could be toxic. So the best way to assess, I guess, could be a biopsy if you're really concerned about if there's an underlying problem there.
So that means there could potentially be a bone marrow issue. So the bone marrow issue could be that the bone marrow is not functioning, or it doesn't have enough raw material, right? The bone marrow needs iron, it needs the nutritional stuff. It needs B12, folate. Have we ruled out all of those causes before jumping to a bone marrow biopsy? There are some things which go against it, right? This patient was microcytic, but I would say it's borderline. If the patient's MCV was 79.4, but you definitely have to rule those out before you move on to the next step. What other things can cause low retic count?
Like if the patient was having, I'm not sure if the patient was thalassemic, like his labs would be keeping with like the iron indices that he have, and we didn't get like an electrophoresis yet.
That's true.
Could have an infection, like a parvo, or if he took any other medications while he was away. Some medications can cause decreased production.
Great. So for parvo, do you know how would you rule it out?
Sorry, for what?
Antibody test, maybe, I don't know.
So for parvovirus, do you have any serology?
Yeah, like we can have like IgG.
IgG, exactly. IgG, IgM. So we think it could be bone marrow, so we do parvo. You still want to rule out parasitic etiologies, so malaria, antigen, any other infections which can cause hemolysis apart from malaria?
Like dengue, I think, can cause it.
Dengue, thrombocytopenia more so. Yeah, Cheryl says babesia, that's more common. That also you rule out in a smear, right? You see a Maltese cross. And that's about it. So we want to rule out infectious causes, parasites. We want to rule out bone marrow suppression from parvo, and we want to rule out B12 deficiency. So we have our plan. All right, let me just go back to the room. If you guys just hang out and here in a minute, and I'll close the build button. I think we're just waiting for 2 rooms to join us back. All right, I think everybody should be back now. Can we have one representative from each breakout room just tell us about what they think are the next best steps? So from room 1, which was Victor's room.
We were thinking about sending a panel for to assess for tick-borne diseases, such as Rocky Mountain spotted fever or babesiosis.
That's a good. Room 2, which is Rafa's room. Does anyone?
First off, we just kind of wanted to talk about like vitamin deficiencies and some things like that, just since it was, even though it was microcytic, common things are common. So like B12, the iron panel that we did, things like that would be first step.
Great points, yeah. And then Omar, do you want to talk about our room?
So we wanted to screen for like causes that cause marrow failure. So we wanted to see like parvovirus antibodies, and we wanted to see also to screen for parasitic infections. And also like the nutritional deficiencies, the basic ones, B12, folate.
Absolutely. And then Dr. Singh's room.
We were
You want to take it away? Yeah.
Yeah, so we were thinking of getting stool ova and parasite, fecal occult. Also want to get transferrin, soluble transferrin receptor, because we want to be sure it's not iron deficiency since this patient is profoundly anemic. And as Tyler mentioned, a vitamin B12 panel too, just because it's it is almost normocytic, and both microcytic and macrocytic at the same time can cause normocytic. So we want to be sure that that's why we want to get a soluble transferrin receptor as well as a vitamin B12 level.
Yeah, good points. Victor, can you show us what happened?
Sure, of course. So along the lines of what you guys said, we did get additional workup for tick-borne diseases and other diseases as well that could cause both anemia and thrombocytopenia, which also fit the picture along the dark spots along the head, the palms. So a chikungunya virus came back positive for IgG, but negative for IgM, and everything came back negative for both IgM and IgG. So Ehrlichia, Anaplasma, Babesia, and parvovirus as well. CMV and EBV IgMs were also done, which were negative. Syphilis serology was done, and it was non-reactive as well. Vitamin B12 was ordered, and this is something that Sonal just mentioned, and it came back severely low at 148. So additional testing was ordered as well with the methylmalonolic acid, which came elevated at 3.2 K. And based on those findings, we opted to additional testing to figure out what the cause of the vitamin B12 deficiency was. So we sent intrinsic factor antibodies and antiparietal cell antibodies, which both of which came back elevated. And soluble transferrin, which is also an indicator of that could help us make a decision regarding iron deficiency anemia, came back elevated at 32. So that was the workup that we ordered. And based on that, the final diagnosis was a diagnosis of pernicious anemia with a possible concomitant iron deficiency anemia. So the case discussion, obviously I'm not gonna go over everything because it's such a vast topic, but I'm gonna go over some pearls that you have to keep in mind, especially when working up patients with anemia. And in this case of vitamin B12 deficiency, it's very important to understand the physiology of vitamin B12 absorption, because if you're able to understand that, you will understand the different mechanisms by which one can be deficient. It's very important to remember the importance of the intrinsic factor, which is secreted in the stomach, and its importance for absorption at the level of the ileum and the GI tract. And when we're thinking about deficiency of vitamin B12, it's either going to be due to decreased ileal absorption, decreased intrinsic factor, genetic causes, which can cause mutations and diseases at the level of transcobalamin, which is a transporter in the blood vessels, inadequate intake, and medication use, the most common of which are a prolonged use of PPIs and prolonged use of H2 blockers for more than 1 year. The importance of B12 is its important role in the synthesis of the DNA, and hence genetic information. And this also all goes back to its importance at the level of the bone marrow in hematopoiesis. This is a picture that I got from our Step 1 book, which is obviously something that is out for us now, but it's very important to remember the cycles, because this is what we're testing for, and this is what we actually tested for. So we usually test for homocysteine, which is elevated in vitamin B12 deficiency, in addition to MMA, which is also elevated in vitamin B12 deficiency because this enzyme, the methylmalonyl-CoA mutase, is non-functional because of the deficiency, in addition to the methionine synthase, which is also non-functional in the case of the deficiency. So, what are the disease manifestations of vitamin B12 deficiency? Manifestations include a hyperpigmentation, which we did have in our patient. Jaundice, vitiligo is also a possibility. Other findings which were present in our patients were anemia and pancytopenia, anemia in our case, and thrombocytopenia, but pancytopenia is also a possibility, with neutropenia being the third contributor to the pancytopenia. And obviously, as we already know, neuropsychiatric manifestations are also a possibility. One of the things that I would like you guys to remember is that vitamin B12 deficiency may cause a picture of ineffective erythropoiesis in the bone marrow, which can mimic blood work markers of hemolytic anemia. And this is basically what we had in this case, with the elevated LDH, a low haptoglobin, and indirect bilirubinemia. This is a picture which mimics hemolysis, but in fact, we do not have active hemolysis either extrinsically or intrinsically in the blood vessels, but rather in the bone marrow, and this is due to the deficiency of the vitamin B12 causing the lysis of the precursors at the level of the bone marrow. However, unlike hemolysis, the bone marrow is hypoproliferative with an absent reticulocyte response. So in hemolysis, you would have expected the retic count to be elevated. However, in this case, the retic count is going to be low. And this is a picture of me during medical school, and the first and only time we saw a hypersegmented neutrophil. And at that time, the hematopathologist asked us to appreciate this. Obviously, at that time, I did not, but now I do. So pernicious anemia, it's always important to remember that anti-intrinsic factor antibodies are more specific than antiparietal cell antibodies. But sensitivity is low for that 37% versus 81% for antiparietal cell antibodies. In addition to a lifelong supplementation of vitamin B12 for patients with pernicious anemia, patients should also be evaluated for gastrointestinal malignancies and other autoimmune diseases for that patients. Patients should also be followed up with GI for further investigation of atrophic gastritis. Unfortunately, our patient was discharged before our vitamin B12 panel came back and before the diagnosis of pernicious anemia was done. And unfortunately, he was lost for follow-up, so he never followed up with GI. The treatment and expectations. Usually, the initial therapy is 100 micrograms of IM B12 for 3 to 4 weeks, followed by 1,000 micrograms once per week for 4 weeks. The maintenance therapy is monthly. Some experts do push for the oral vitamin B12 use in pernicious anemia. However, this is still controversial. And how do you follow up the improvement? That would be by homocysteine, MMA, and retic count, which usually improves within 1 week. Neurological symptoms, if present, within 6 weeks to 3 months, and eventually the anemia, leukopenia, MCV, and thrombocytopenia resolve within 8 weeks. So take-home messages. Vitamin B12 deficiency can present as pancytopenia, which is, in our case, it was a bicytopenia, but pancytopenia is a possibility. It can also present with a picture of hemolysis with a hypoproliferative marrow. When you look at the retic count, the retic percentage in EPIC, it usually is the retic percentage when we order the retic battery. It's very important that you calculate the retic index. If I'm not mistaken, the retic percentage that we had in our case was a 0.9, which reflects a normal retic count. But if you calculate the retic index, it shows that the bone marrow is hyperproliferative. 2 different types of anemias could be present at the same time. So even if we get an MCV, which is low, and we still do not have an explanation for that, think about another possibility of a macrocytic or a normocytic anemia, which might be concomitant. And a soluble transferrin receptor is a more precise indicator of true iron deficiency, which is usually elevated in iron deficiency anemia. That being said, always keep in mind one thing, that when we get iron studies during a hospitalization, those can be falsely elevated or falsely low because of the concomitant diseases occurring during a hospitalization. So it's always important to retest those as in the outpatient setting once everything settles down. And basically, I think Dr. Singh would be the best person to comment over here, but we could see what the best practice cost for the essential things that we could have ordered totals to be around $150, which could have ended up giving us the diagnosis that we had versus everything that we ended up eventually ordering, which is a 2.1K bill. That is obviously just the labs that we ordered, not including the admission, not including all the other charges for the hospitalization.
So a couple of things. I think, Sonal in our small group had sort of beautifully highlighted the point of, checking the levels of sort of the nutritional deficiencies, right? So B12, iron is not expensive. And, if you've done a sort of a preliminary workup and you haven't reached a conclusion, then start thinking about that normocytic range as potentially being a combination of micro and macrocytic. Right. So if you look at the costs, B12, checking a B12 is fairly cheap, right? Checking iron studies is not terribly expensive. And so all of those are pretty low cost things to do, which clearly in like Victor's case, gave him the diagnosis. I don't know what the cost of the intrinsic factor antibody and the antiparietal cell antibody is. I tried to look up the healthcare blue book, but I haven't been able to find those costs. It's a little bit higher, I expect. It's not going to be in the $10, $20 range. It's going to be $30, $40. But obviously, once you reach the diagnosis of this being true B12 deficiency, it's really important to get to the bottom of why, because it affects how you replete your vitamin B12, right? You can either confidently do it orally or confidently know that your oral repletion is going to do nothing if there is actually an intrinsic factor antibody. When I was discussing this case with Angad said, well, this guy walked in with chest pain. He walked in with shortness of breath. Wouldn't you get a troponin? Wouldn't you get a BNP when you first saw him? And if you just look at the cost, so a troponin costs you $16 and a BNP costs you $25. They're not terribly expensive. Now, this is for a Medicare patient. If you are privately paying for this, this is about $150 each. So it's not terribly expensive, right? So if I can be very confident you're not having a heart attack based on a troponin, sure, I would probably get it. But again, the approach should be, and even as we spoke with the hematology specialists, to kind of get their guidance on what's truly necessary workup and what was wasteful here. They said, whatever you do it in a stepwise fashion, right? So check a CBC and a CMP first. If you didn't get your answers from that, and you're still worried that this person's having active chest pain, yes, a troponin is justified. But if you got your answers, this person is severely anemic, then do they really need a troponin and BNP, right? So instead of the kitchen sink approach, perhaps a more careful approach of saying, let me have a stepwise thought process. And, Darren, you don't agree? So the other thing is just to remember, not everyone who walks through your door needs a chest, CAT scan. Not everyone who walks through the door needs a TTE. This morning my team was presenting a syncope case. My excellent intern beautifully wrapped up the case and said, Dr. Singh, this is vasovagal syncope. And I said, yes, it is. Phenomenal. And he goes, I'm getting a TTE. So I said, oh, wait, what? But you just said it was vasovagal and you proved it was vasovagal and you're still getting a TTE, right? Why, right? So when you have a diagnosis, right, don't go chasing after a third diagnosis. You have like a great diagnosis here. So just thinking a little bit, because ultimately these are your tax dollars, right, for all your Medicare, Medicaid patients, and everyone that's private pay insurance, they actually leave the hospital with a bill. And the very, very sophisticated patients will call me and say, why did you give me 3 bags of saline? Do you know that a bag of saline costs $500 to infuse? And the very sophisticated ones will tell me how much it cost them a month after their hospitalization. If we go back, there's just a couple of more points I want to make. Victor, just go back to your previous slide. We were just discussing the validity of the soluble transferrin receptor. And Victor, can you just tell everyone what is a soluble transferrin receptor?
So the soluble transferrin receptor is part of the receptor which gets cleaved into the circulation. And you would expect in an iron deficient patient, because we're trying to get more of the iron to be circulated and more of it to be stored, we expect more cleavage of that part of the receptor to be cleaved into the circulation and hence be detected by our the test that we usually do. So we expected an iron deficiency to be elevated.
Okay, excellent. So that's really important to understand because, a few years ago, we didn't have this test. It didn't exist, the soluble transferrin receptor. So we were always relying on the ferritin, and we know the ferritin is also an inflammatory marker. Now, just because we've taught you about the soluble transferrin receptor doesn't mean everyone needs it, right? So a ferritin is still a great test to look for iron deficiency, a value less than 20 in the absence of inflammation, right? You'll get that value for an iron deficient patient. It is conclusive for iron deficiency. We used to teach the value of 15 back in the day. It's moved to 20 now for ferritin. And you can rely on that. And you don't need a soluble transferrin receptor in that setup, right? But when you start to see values like ours, like in 3 digits, and there's some ongoing inflammation and you're uncertain, that's where it becomes super helpful to get a soluble transferrin receptor. Not everyone needs it. Stepwise fashion, get your ferritin first. And then go to this. And then there's a utility also, the soluble transferrin receptor ferritin index,
yes,
which maybe Victor can teach us another time.
Sure, of course. But it's a combination of both the ferritin and the transferrin receptor, which it's a messy calculation by the end of which you can be sure whether this is iron deficiency versus anemia of chronic disease.
The interest of time, we'll leave that for another day.